Well, thank you all so much for inviting me here to speak with you today. OCRA is such an amazing group. I'm really honored to be here and to chat with you today about rare care. So caring for patients with rare GYN oncology cancers. My name is Jubilee Brown. I am the professor and division director of GYN oncology at the Levine Cancer Institute at Atrium Health, Wake Forest University, here in Charlotte, North Carolina. And I'm also the GYN oncology lead for EarCap, which is a North American installation of really an incredible innovation and research and surgery group. So with no further ado, we'll switch on to talk about my disclosures. I do some research consulting with Verastem, Caris, GSK, AstraZeneca, Eisai, and Genentech in the past several years, but none of these will affect what we talk about today. And so today we'll go ahead and we'll describe the problem, the past treatment, the present, and the promise for the future for each little bucket of rare tumors. And the idea here is to put all this together and synthesize the best evidence for the treatment of rare ovarian, uterine, and cervical GYN cancers. So we'll talk about ovarian cancers first, and we'll divide these into sort of the three major groups of ovarian cancers. Those are epithelial, germ cell, and sex cord stromal tumors. And then specifically, we'll talk about uterine cancers, and the rare tumor that I'd like to highlight there is leiomyosarcoma. We'll mention cervical carcinomas and specifically neuroendocrine carcinomas. And then we'll talk about molecular profiling and platform testing because it's so important in everything that we do with regard to rare tumors. And we'll summarize with just those take-home points. We'll frame every one of these things with the problem, the past, the present, and the promise for the future. So let's start off with ovarian cancer. And when I think about ovarian cancers, I like to categorize these things in my head, right? Ovarian cancers can come from three separate parts of the ovary. So if we look at this little diagram here, we see the ovary and it has this outside covering on it. Any cancer that comes from that outside covering is considered epithelial. We also have germ cells, so those cells that essentially make the eggs within the ovary. And then we have cancers that come from the supportive tissues, the sex cord stromal tumors. What we'll focus on first is the epithelial tumors. So those tumors or cancers that come from the covering of the ovary, those are all deemed epithelial tumors, and they're the most common type. They represent actually 90% of ovarian cancers. But even within that bucket of epithelial tumors, there are several sort of more rare types. So many of you probably know this, but if you go and you Google ovarian cancer, almost everything you find is going to be related to high-grade serous carcinomas. What we're going to focus on today is what you don't see on your Google search. It's going to be the low-grade serous carcinomas, the mucinous carcinomas, and the clear cell carcinomas of the ovary. And you know, in the past, these have been largely ignored, but they are different. They act differently from the more common high-grade serous carcinomas. So, you know, literally nothing you read about high-grade serous applies to these other types. And so it's important to separate them out and know that, you know, if you're a patient with these, you are important and your treatment is not just like, quote, everybody else. So low-grade serous carcinomas, the problem is they're rare, 5% of all epithelial cancers, but they're serious. So 70% of advanced stage patients relapse. It turns out that conventional chemotherapy, the things that we use for high-grade serous carcinomas, is just not effective. And in fact, different pathways drive these tumors. So the reason these cancer cells divide is because of different pathways in the cells, in those cancer cells, being revved up and overactive. So it turns out that over half of patients with low-grade serous ovarian carcinomas have activation of the MAP kinase pathway. And when we look at this, it's KRAS mutations, it's BRAF mutations, and NRAS mutations. And the reason this is important is that these often will respond to MEK inhibitors. It's not your standard chemotherapy. This is a targeted treatment that acts differently than conventional chemotherapy. And I'll show you today, it acts better for patients with low-grade serous carcinomas. In addition, the majority of low-grade serous carcinomas are actually hormonally active. Almost all of them have estrogen receptors. And so we can target these cancers with hormonal therapy a lot of the times. It turns out that when we look at low-grade serous carcinomas, over half of patients have actionable mutations. And so we'll get into what this means. That means that if you look at the molecular profile of patients with low-grade serous carcinomas, over half have something that we have a medicine to treat. That's amazing. So in the past, we treated everybody with paclitaxel and carboplatin, but it turns out that only about half of patients were disease-free right after their chemotherapy ended. Well, that's not great. And it turns out that only 4% of 25 patients with advanced stage disease actually responded to upfront chemotherapy. That's especially not great. And it turns out that in 4 randomized phase 3 trials that encompassed over 5,000 patients, women with low-grade serous carcinomas were much less likely to respond. Well, that's a problem. So currently, paclitaxel and carboplatin are the standard of care. But what's so important is that we have a trial looking at letrozole. This is a hormone blocker, so an aromatase inhibitor. And this appears to be useful. In fact, this chemotherapy that we've used for so long is actually being replaced by letrozole. And this trial, this is the promise in upfront low-grade serous carcinomas, GY019. It's a randomized trial where patients are treated with paclitaxel, carboplatin, and letrozole with maintenance versus letrozole only. This is over halfway finished. It's accruing very quickly. So within a couple of years, I think we'll have an answer to this. And hopefully we'll be able, what this means is we'll be able to drop chemotherapy and just treat with a pill, letrozole, very effective. Letrozole monotherapy, meaning that these patients would not need chemotherapy at all. Remarkable, actually. So this is the promise for newly diagnosed patients with low-grade serous carcinoma. What if it comes back? So sometimes low-grade serous carcinomas come back. Again, we mentioned that, upfront chemotherapy doesn't seem to work well. What are our other options? Well, at the present time, we have hormonal therapy. We also have MEK inhibitors like trametinib that are able to target these cancers. And so here, for example, is a patient of mine who before trametinib, you can see that red arrow there. She had a lot of disease present. She was having to have taps, like drainage of fluid of ascites in her abdomen every 2 weeks. And shortly after starting trametinib, you can see it's gone. She had a complete response. And, this is the key. This patient, as so many others should have, had molecular profiling. She was KRAS positive. So we knew that she was a great candidate for trametinib. And as you can see, we were able to use that information to target her tumor, and she responded. Great stuff. Well, what about the future in the recurrent setting? This is so exciting. So we now have a combination of 2 drugs called avutometinib and defactinib, and they work together to block this overactive pathway and basically clamp down on a resistance pathway to get really great responses. And so if we look at the RAMP 201 trial, really just a remarkable response rate of 45% response rate, and it was very tolerable. So now we have the next phase of this, RAMP 301, again, looking at this very unique combination in patients with low-grade serous carcinoma. So our take-home points for this rare tumor: upfront paclitaxel carboplatin is likely to be replaced by letrozole, and so stay tuned. GY019 will answer this. in the recurrent setting. So if this cancer comes back, we know that we have MEK inhibitors and hormonal therapy like letrozole that are approved. And the RAMP 301 trial is ongoing, which will hopefully give us even more approved options. It's great times to study rare cancers. So if we segue into our next rare epithelial ovarian cancer type, that's a mucinous carcinoma. And it is sort of what it sounds like. It makes a lot of sort of mucinous or mucus type secretions. These tumors tend to be very big and they're different. Basically, Will Winter, my friend who looked back at the different subtypes of epithelial ovarian cancer, what you can see on this panel over here on the right is that patients with different ovarian cancer types did differently. When these lines here separate, that means that patients with endometrioid cancers did better, serous cancers did better, but this red line, mucinous cancers, they don't do so well with taxane and platinum therapy. And so in the past, just like almost everything else, we treated these patients with paclitaxel and carboplatin. We have started to search for a better therapy. Maybe, these tumors look a lot like colon cancers or GI cancers. And so we look to see, can we use a GI regimen, looking at capecitabine oxaliplatin instead of paclitaxel carboplatin, and does bevacizumab help? So basically, we had this very nicely designed trial that looked at these 4 different options of treatment. Unfortunately, we had to stop that trial because these cancers are so difficult to identify that there was so much confusion from a pathology standpoint that a lot of these tumors that were thought to be ovarian cancers actually ended up being colon cancers. And so the entire trial had to be scrapped and shut down. So unfortunately, we got probably the most useful information from this was that when these trials are done on rare tumors, they need a centralized pathology review to make absolutely certain that we're treating the right patient with the right drugs. The promise for this, it turns out, is that KRAS, that same sort of mutation, is overexpressed in over half of patients. And many of these tumors are targetable. Almost 20% have a HER2 mutation. And the reason that's important is because they are targetable. If someone has a mutation in HER2, we have an anti-HER2. We actually have several drugs now that target HER2. And so these patients, all of them should be tested, and central pathology review should be entertained. These are rare enough that we're not actually exploring these as a separate silo. I don't think I mentioned I'm the co-chair of the Rare Tumor Committee within the NRG, which is the largest cooperative group. Basically, that's the group that we study all GYN cancers in the country, and actually now international, many countries. And so we're able to conduct a trial in a lot of different locations so we can answer these questions and bring useful therapies to our patients quickly. So with mucinous carcinomas, I think we should consider the non-paclitaxel carboplatin regimen of capecitabine oxaliplatin, though we don't have great proof for that. Everybody, should have their pathology reviewed to exclude a colon or a GI primary. And so the third type and final type of rare epithelial ovarian cancer that we'll talk about today is clear cell carcinoma. And so, what's the problem? These tumors, they're rare, but they can happen in young women, usually in the late 40s to 50s. And unfortunately, they're often platinum resistant, meaning that the conventional chemotherapy that we try to use doesn't work very well in advanced stage patients. And so in the past, really nothing worked. And here's the laundry list of trials that we've looked at to try and find something that worked well. None of these trials showed any real great activity. But there's some good news out there. So the Annie study looked at 2 drugs, enlotinib and niraparib. That's an oral anti-angiogenic. So basically it prevents new blood vessel formation, and an oral, so a pill, PARP inhibitor, so commonly used. And 50% of the time it worked. Now it's not perfect. The median overall survival was still only 15 months, but it did add something to what we, were able to achieve previously. I think one of the most important things in clear cell carcinomas is immunotherapy. So this was initially reported back in 2015 when one patient with clear cell carcinoma essentially had a complete response to a very well-tolerated immunotherapy drug. And what does immunotherapy do? It revs up your immune system so your own immune cells can identify and target and kill the cancer cell that's in your body, right? So clear cell carcinomas can often be recognized by our immune system. And in fact, the marker that we sometimes have used, PD-L1, didn't even correlate with the response. So it turns out that many of these patients with clear cell carcinomas may respond to immunotherapy. So here's a wonderful patient of mine who was treated with immunotherapy. I met her after she had failed conventional chemotherapy. She hadn't failed, but it didn't work on her tumor. And then the cetuximab that she was given on trial didn't work. But she was PD-L1 positive when we sent her tumor off for evaluation. And you can see those bright spots on her PET-CT. Those bright spots are bad. Those are the cancer in her liver, in her supraclavicular lymph node area up here in her neck. 6 months after she started on immunotherapy, it's gone. In fact, it stayed gone, and we just stopped her treatment completely because there's no evidence of disease at all. So what a great story. And patients with clear cell carcinoma, this never used to happen. And now with immunotherapy, it does. In fact, Don Dyson presented the BRUOG 354 study with ipilimumab and nivolumab. Hard to say, so everybody just says ipi-nivo, but it looks like for patients with ovarian or gynecologic clear cell carcinoma, this is more data to show us that the clinical activity and survival outcomes are best with the combination of ipilimumab and nivolumab. No new safety signals, and again, underscores the importance of immunotherapy in patients with clear cell carcinoma of the ovary. There are currently 178 trials internationally ongoing in clear cell carcinoma of the ovary. So stay tuned. I think we'll see a lot more information and hopefully drugs that work against clear cell carcinoma of the ovary in the very near future. So we've talked about epithelial tumors. Let's switch to germ cell. Again, these come from almost like the egg cells, if you will. Germ doesn't have anything to do with, infection. Think about germ like a flower germinates, right? So these are the seeds, these are the eggs. When we talk about germ cell tumors, what we're talking about are dysgerminomas, yolk sac tumors or endodermal sinus tumors, immature teratomas, choriocarcinomas, or embryonal carcinomas. They're really rare, and they tend to happen in young women or young girls. They're often, more than often, almost always curable. And so the key here is not to overtreat patients with these tumors. And turns out since the 1980s, all patients with malignant ovarian germ cell tumors have received 3 to 4 cycles of a fairly toxic regimen of bleomycin, etoposide, and cisplatin that we'll call BEP after their hysterectomy and staging, which included a lymphadenectomy. Well, it turns out that we've made a lot of advancements in this area. Again, remember I said most of the time these happen in young girls, adolescents, young women who want to potentially have the opportunity to have children someday, right? Well, it turns out that fertility-sparing surgery is actually very safe to do. And many of these tumors are very chemosensitive. So I'll skip through the details, but essentially say that it turns out that we can actually not treat many of these patients with early stage disease with chemotherapy. And so that really saves them a lot of toxicity from the BEP chemotherapy with, as you see, patients with stage 1A and 1B fully staged patients have 100% 10-year overall survival. Basically, that means these patients are cured. Of the patients where it came back, they're cured with chemotherapy. So it means that 85% of the time, when we used to treat patients with this pretty toxic chemotherapy regimen, now they don't have to get treated. Only 15% of patients actually have to get treated. So great news and great cure rates. The promise here is really kind of shrinking the numbers of patients with germ cell tumors who are requiring treatment. It turns out that most patients we can watch and wait. And so that's under investigation. We're trying to get some really solid parameters around that, but good news. The trial that we have is AGCT 1531. So if you hear about that, that's all about ratcheting down chemotherapy and substituting carboplatin in for cisplatin. So again, like less toxic. One very important limitation is that patients with yolk sac tumors, they just don't do as well as other histologies. So all of these patients really need to be treated. The last bucket that we'll talk about in epithelial cancers are the sex-scored stromal tumors. And these are tumors, this is where I've done most of my work, research-wise, through really my whole career of 25 years or so. Sex-scored stromal tumors come from the supportive tissues. And these are largely tumors like granulosa cell, both adult and juvenile, and sertoli Leidig cell. Sex-scored stromal tumors tend to be on one side. They can bleed, but the thing is they're slow growing, but they can recur many years after initial treatment, even decades. Interestingly, we found the specific mutation that appears to be the driver mutation for these cancers. And so hopefully soon we'll be able to target that. Juvenile granulosa cell tumors are separate and they can be more aggressive. So we treat every patient who has more than just a stage 1A juvenile granulosa cell tumor. Sertoli Leidig cell, they look different, they act a little bit differently, and they're described a little bit differently. But again, we don't tend to treat patients the same as we used to. In the past, we used to treat everyone with BEP, but the response rate was very limited and the length of response was limited, and it was pretty toxic. Patients had major pulmonary complications like lung problems from the bleomycin. In addition, we've made some massive changes and improvements, and I have loved to be involved with this through my career. We do not routinely take out lymph nodes in these patients anymore because essentially it doesn't go to the lymph nodes. In addition, we're just publishing now the results of GOG 264, which show that paclitaxel and carboplatin, though it's not better than BEP, statistically, the progression-free survival was actually like on average better, 27 versus 19 months, but it did not reach statistical significance. Overall survival, these patients do so well that the overall survival was not reached, median overall survival was not reached in either group, which basically means the majority of people are alive and well, even though they've had this granulosa cell tumor develop. So paclitaxel carboplatin appears to be a less toxic alternative to BEP, and that is good news for patients who have sex-scored stromal tumors. There are lots of different ways that we can treat patients with sex-scored stromal tumors, like granulosa cell tumors and sertoli Leidig cell tumors, and those include surgery, radiation, hormonal therapy, now paclitaxel carboplatin, as well as bevacizumab plus or minus paclitaxel. And the good news is we've shown through a number of different studies now that we can rapidly complete these studies on patients with sex-scored stromal tumors. So this actually shouldn't say germ cell, sorry, that should say stromal. The promise is the future. We have lots of trials ongoing, and those include GY033, that's on hold right now, looking at an androgen receptor inhibitor, darolutamide, as well as other hormone blockers, exemestane and leuprolide acetate. There's a trial looking at a Notch inhibitor, and there are multiple trials in development. I'll give a little shout out here to Tyler Hillman. His lab is looking at other really novel ways to slow or stop granulosa cell tumors. And so I'm really excited to see what comes out of his lab next. Lots of movement on this front. So we've covered ovarian cancer, epithelial, germ cell, and sex cord stromal tumors. And now let's switch to uterine cancers. And I'm going to very specifically talk about leiomyosarcoma. The problem is that these tumors, they come from sort of the muscle layer. Leiomyosarcoma means smooth muscle cancer. And you can see at the bottom, this patient of mine who had really massive tumor. Her entire pelvis is just filled with this leiomyosarcoma. And that's the rule. These are often very aggressive. Even patients with stage 1 disease have a 50 to 80% recurrence risk at 3 to 5 years. Like, these are bad actors, no matter what you do. And to date, surgery has really been the only option with potential cure for patients with a limited leiomyosarcoma. Turns out that adding radiation in, following with chemotherapy, it doesn't impact overall survival at all. We've studied lots of things. So if we look at adjuvant therapy, so basically therapy after surgery for women who have early stage uterine sarcomas, you can see that basically every year there's been a new study, and none of them have shown an improvement over baseline. The Geddes trial design actually looked at comparing 2 different arms, a single agent doxorubicin with an investigational arm, so gemcitabine and docetaxel together. I think we all expected that the gemcitabine and docetaxel would do better than the doxorubicin or adriamycin arm, but it turns out that wasn't the case. So overall survival actually was statistically no different between the two. And the single agent, of course, had fewer side effects. So this really brings doxorubicin up in front for us in terms of the preferred regimen. So basically 2 active regimens, doxorubicin and the combination of gemcitabine and docetaxel, but really this elevated doxorubicin back up to something that we use much more frequently. So I think where we are now is that observation is reasonable in uterine limited sarcoma. There's no survival benefit from the combination chemotherapy, and single agent doxorubicin is still recommended as the reference arm for trials and also as palliation. Sometimes we do still use combination therapy if we're trying to shrink tumor for symptom control, or if somebody's failed, if doxorubicin hasn't worked for a specific cancer, or if the disease is life-threatening imminently. The promise, however, is that it turns out that many of these cases actually have hormone receptors present. And so we may be able to use letrozole in these patients. And that's being studied in GOG 3088. In addition, there are some studies that have looked at embolization and thermal ablation, basically interventional radiology ways to target these tumors. Turns out there are 74 studies ongoing at the present time in leiomyosarcoma. So hopefully we'll have some new news, in a short period of time. So we'll talk next about cervical cancers. And specifically focus here on neuroendocrine carcinomas of the cervix. These are super rare. So less than 2% of cervix cancers are neuroendocrine, but they are very aggressive. They tend to have nodal involvement and they tend to spread, so metastatic disease. 5-year survival is only 36%, and the median overall survival is 22 months. So boy, there's a reason to try and do better in these patients. In the past, there's really been no standard of care. At present, the combination of surgery, radiation, and combination chemotherapy in the form of EP, so etoposide and cisplatin, is the standard. And this is worth calling out because it's very different than how we treat other types of cervical cancer. In addition, we see that in recurrent disease, like if the cancer comes back, paclitaxel, topotecan, and bevacizumab may have some role. One of the things that I think is very promising is what's called the Nectar Registry. So my, unfortunately, late colleague, Michael Frumovitz, who many of you probably know, he was my partner for a long time and unfortunately just passed from pancreatic cancer. And it's a loss as a friend and a loss as a colleague and a loss as a doctor. He put together with a group of survivors a registry called the Nectar Registry. And this is something that we had all been trying to do for a long time, but Michael was able to get it done along with partnership, with patients and survivors. And basically, with these rare tumors, it's so important to be able to collect data so that we know what works and what doesn't work. I may see just a handful of these patients in my whole life, right? But if we pile together everybody in the country over 10 years, 15 years, 20 years, we're going to get a lot more information. So I think this Nectar Registry really showed that that kind of information gathering can be done and done very successfully. Another sort of rare type of cervical or uterine cancer is something called PEComa. Incredibly rare, but it stands for perivascular epithelioid cell tumor, PEComa. And, this is just a huge shout out to Tom Herzog and to the pharmaceutical company who focused in on a rare tumor when many pharma companies are not interested in studying rare tumors. These folks were. And so this year at the SGO annual meeting, Dr. Herzog presented on the AMPEC trial, which is a drug, it's a targeted therapy called nab-sirolimus, and it works in these patients. Literally nothing worked in these patients with PEComas in the past. But in this phase 2 trial, 31 patients were treated, 12 responded, but 2 of them, it completely went away. And in fact, patients did so well that the median duration of response wasn't reached at a median of 36 months. So what does that mean? That means 3 years later, people were still doing well. Their cancer was controlled or gone. So that's really remarkable in this tumor where previously patients had no options. Now we have nab-sirolimus, and I would say that it is specifically because somebody took the time and the effort to study it. So that sort of winds up the specific examples of what I wanted to cover in terms of ovarian, uterine, and cervical rare tumor types. What I'd like to do now is share a little bit about molecular profiling and platform testing. So why talk about this? So basically, we see very poor responses in rare tumors compared with more common tumors. And so, I mean, this is GYN cancer all in all, compared with things that are more common like prostate, breast, lung. However, there are lots of additional issues. Perhaps the reason that we tend to see poor responses is because it's hard to conduct clinical trials in this area and find out what actually works. It's a challenge to accrue to these rare tumor trials. Many institutions don't want to open them because it's expensive to open a trial. And if you're only going to put a couple patients on trial, institutions don't want that. So it's required people like me and my colleagues to really advocate over and over and over to open these trials and, to find institutions like my own that are very supportive of helping patients, right? It's not just about the numbers or the revenue. It's about how do we help patients with a really significant unmet need. And that's what's important. It's a challenge to gain meaningful data from just small cohorts. I was lecturing my fellows this morning about vulvar melanoma, right? One of the largest studies we have, it's only 23 patients. Compare that with, a breast cancer trial that easily in a very short period of time accrues a couple thousand patients, well, that's the difference in doing studies in rare tumors. Historically, we've studied one drug for one tumor type at one time. And now we're looking at, is there a better way to do studies? So in the past, basically, we did everything with paclitaxel and carboplatin. And now we know we can do better. So let's talk about comprehensive molecular profiling. What does this mean? This isn't really genetic testing, right? Genetic testing is where you get a blood sample drawn and it looks at basically the cells that are everywhere in your body, like our normal cells, the DNA that makes up every cell in our body. It looks for an inherited mutation, right? That's not this. This is molecular profiling, which takes a person's very specific cancer, takes a little pinch of that cancer and sends it off to a lab. Where molecular profiling is done, it gives you almost like the personality of that specific tumor. So what this does, it allows us to recommend treatment after we really understand a given person's specific cancer, right? Not just the type of cancer, not like ovarian cancer, not even like clear cell carcinoma, but like my specific tumor, what's the personality of my tumor? What's the molecular profile? And so when we send this off, there are multiple labs that do this, but essentially it allows us to base treatment on genomic drivers of tumorigenesis, basically what makes the cancer grow in that specific cancer. And we have seen dramatic responses in treatment refractory disease. So you've seen two examples of that. My patient with clear cell carcinoma who got immunotherapy because she had a PD-L1 mutation, well, you know what? Her tumor's gone, right? That's what we're looking for. And so basically this broad panel testing measures levels of genes or products of genes and essentially identifies almost like biomarkers of response. And it turns out for clear cell carcinomas, for example, over half of patients with clear cell carcinomas have actionable mutations. So we see this here. So half of patients have an ARID1A mutation. Almost half have a PIK3CA mutation. 11% have a KRAS mutation. And these are things that we might not know if we didn't test a specific person's tumor, because it's not like every person has a KRAS mutation, which is targetable, only 11%, but you can't tell which 11% unless you test the patient. So, so the recommendation then is for every person with a rare tumor to have that tumor tested and profiled, molecular profiling. Now, the really cool part about this is that we have been able to incorporate that into clinical trials. So the Bouquet trial, I helped design this trial, was on the steering committee for this trial, love this trial, because it takes women who had epithelial ovarian cancer of rare histologic subtypes. And these are things like rare, low-grade, clear cell carcinomas, mucinous carcinomas, undifferentiated carcinoma, malignant Brenner tumors, like super duper rare tumors who've been heavily pretreated, and basically allows us to figure out which drug we think is going to be most helpful for that patient based on their tumor's personality, based on their tumor's molecular profile. Okay, so for example, if you have a rare tumor that has a mutation in BRAF, KRAS, or NRAS, or an NF1 loss of function alteration, then that patient could get cobimetinib. Whereas, if somebody had a PIK3CA mutation, they would get inavolisib or palbociclib and palbociclib. So basically, the arm of the trial, the option for treatment would depend on the molecular profile. Now, we were able to complete a number of these arms and get a number of really great findings from these that have been published and presented and continue to be published and presented, including at the upcoming IGCS meeting. But unfortunately, the sponsor closed the trial What I would say is that's not a failure. I think that this showed us that this is feasible, that we can accumulate a lot of data and really maximize return for patients. So in other words, if I'm a patient with a rare tumor, I have probably a higher likelihood of responding to something that is targeted for my specific tumor rather than just something based on how my tumor looks under the microscope, right? And so that's the benefit of these platform trials. There are actually a number of other platform trials that are now ongoing. We're designing another one through NRG as we speak. But Combo Match is ongoing, Taper is ongoing, and these are really great opportunities for patients that are, again, directed based on their molecular profile. So I think, we've come a long way. 20 years ago, we didn't study rare tumors. There was no mechanism. And now the largest cooperative group that we have, called the NRG, has a rare tumor committee, and we've identified 3 different silos for a comprehensive study that puts together laboratory investigation along with clinical trialists in combination with the NRG group, so that we can hopefully really make a dent in patients with rare tumors and improve outcomes. In addition, GOG Partners is more industry-focused trials, and they also have committed to studying rare tumors, which is fantastic. I think the platform trials are really the pathway to future study. And so just to circle back, I think it's always helpful to, once we go through a lot of material, let's go back and review our take-home points. So what about low-grade serous carcinomas? Up front, I think we're likely to see paclitaxel and carboplatin be replaced by letrozole, and the ongoing GY019 trial will answer this, hopefully in the next 2 years. If the disease comes back, so recurrent setting, we have a number of different options now that just a couple of years ago, we didn't have any of these. So MEK inhibitors and hormonal therapy like letrozole are already approved. And the RAMP 301 trial, super promising and ongoing at present. For mucinous ovarian carcinomas, we're going to consider capecitabine and oxaliplatin with or without bevacizumab, making sure that we review every single patient's pathology to make sure that it is not a colon or a GI primary, but indeed a malignant ovarian tumor. And we can exclude lymphadenectomy in these patients. For ovarian clear cell carcinomas, we know that paclitaxel and carboplatin is currently the standard of care, but immunotherapy in the recurrent setting looks the most promising. For germ cell tumors, fertility-sparing surgery is safe in these young women with germ cell tumors. And we know that it's safe to restrict therapy because these tumors are so chemosensitive. We do not have to treat patients with fully staged stage 1A and B dysgerminomas anymore. And we know that we're expanding these indications studying now. We know that it's okay to watch and wait for all patients with stage 1 dysgerminomas and stage 1 grade 1 immature teratomas. Everybody else still gets treated, and patients with yolk sac and mixed histologies with yolk sac tumors very, very carefully consider surveillance only in a few patients. Everybody else gets treated. With sex-scored stromal tumors, and again here, this is adult and juvenile granulosa cell tumors and sertoli Leidig cell tumors. We don't need to do routine lymphadenectomy in these patients because that just simply doesn't go to the nodes. Upfront setting, we know that we can use paclitaxel and carboplatin in most patients, giving us another option in addition to the more toxic BEP. And in the recurrent setting, at present, we have surgery, radiation, hormonal therapy, paclitaxel, carboplatin, and bevacizumab with or without paclitaxel. We know that sertoli Leidig cells are a little bit different, so we have to be careful when we treat these patients. And that there are other studies ongoing at present. Hopefully we'll have even more information in the very near future about who with granulosa cell tumors and sertoli Leidig cell tumors we need to treat and what our other options are. When we switch to uterine leiomyosarcomas, we know that observation is reasonable in uterine limited sarcomas, that there's no survival benefit from combination therapy, and that single agent doxorubicin is still the preferred arm, and that occasionally we can use combination therapy. For cervical neuroendocrine tumors, we think of a combination of surgery, radiation, and EP therapy, but that with PEComa, we've seen success with nab-sirolimus. And with that, I'd like to shout out to all of you and thank you for your commitment to listening, to thinking ahead, to being patient advocates, and I just thank you all. I'd also like to shout out to my team of teams, my entire group here at Levine Cancer Institute, Atrium Health, my amazing partners, both physicians as well as nursing fellows, just the whole group. It's not one person, it's the whole team. So thank you so much, and I look forward to connecting with many of you in the future.